Dry socket, also called alveolar osteitis, is one of the most painful complications following tooth extraction. It occurs when the blood clot inside the extraction socket is lost or dissolves, leaving the bone exposed and delaying the healing process. Definition: dry socket is a painful post extraction condition that develops due to the premature loss or breakdown of the blood clot inside the socket. As a result, the underlying alveolar bone becomes exposed, leading to severe pain and delayed healing. Incidence: dry socket is more commonly seen after mandibular molar extractions. It usually appears during 2 to 4 days after extraction. The incidence is higher in females, in smokers, and in patients using oral contraceptives. Etiology: predisposing factors. Several factors increase the risk of developing dry socket. These include traumatic extraction, excessive manipulation of the socket, poor oral hygiene or local infection, smoking and tobacco use, oral contraceptive intake, vigorous rinsing or spitting after extraction, and systemic or medically compromised conditions. All of these interfere with blood clot stability. Pathogenesis, fibrinolytic theory. The most accepted explanation is the fibrinolytic theory. A stable blood clot is essential for healing. However, when fibrinolytic activity increases, the clot breaks down and gets dissolved. This exposes the underlying bone, leading to inflammation and severe persistent pain. Because of this mechanism, dry socket is also called fibrinolytic alveolitis. Clinical features: dry socket typically develops 2 to 3 days after extraction. The pain is severe, throbbing, and radiating, often extending to the ear, temple, or neck region. On examination, the socket appears empty, with exposed bone and grayish necrotic debris. Patients may complain of foul smell or bad taste in the mouth. Healing is delayed, and usually there is no fever and no pus discharge. Prevention. Prevention plays a key role in reducing dry socket. Important preventive measures include atraumatic extraction technique, adequate irrigation, avoiding vigorous rinsing or spitting, strict avoidance of smoking after extraction, pre- and post-operative chlorhexidine rinse, and minimal instrumentation of the socket. Management. Management of dry socket is mainly palliative. The socket is gently irrigated with saline or chlorhexidine, and necrotic debris is removed. Medicated dressings may be placed, such as eugenol dressing, Alvogel, or zinc oxide eugenol. Analgesics or NSAIDs are given for pain relief. Warm saline rinses are advised, and dressings are changed until the pain gradually subsides. Antibiotics are not routinely indicated unless there is evidence of infection. Prognosis. Dry socket is a self-limiting condition. Symptoms reduce after medicated dressing, and complete healing usually occurs within 7 to 10 days.